Good morning and welcome to the Health and Social Care Overview and Scrutiny panel. I would like to do a few housekeeping rules first. A fire practice is not expected. If the alarm sounds, can you all present leave the building as quickly as possible by the way of the nearest exit. The designated assembly point is in the public square in front of CAS, beyond the fountain, away from the civic office. If there is anybody with mobility issues, please wait in the refuge area at the top of the stairs, where the emergency evacuation lift is located, and use the intercom situated to the left-hand side of the lift doors to call for assistance. No roll call will be undertaken. Thank you. Mobile phones. In addition, I would like to ask everyone to ensure that your mobile phone and laptops are switched to silent mode, please. This meeting will be audio-visually recorded and will be available to view on the Council's website and YouTube channel. Can I ask all present to use their microphones to ensure the audio can be captured? Any members of the public entering the Council chambers are accepting that their images will be retained and broadcast for the Council. If any member of the public or press is intending to record or film any part of today's meeting, please ensure that this does not disturb the conduct of the meeting. If you are visually recording, you are requested to only focus on recording. Please can I ask that everyone introduce themselves, starting with myself, Councillor Hollingworth, Chair of this meeting.
Councillor David Carroll, Vice Chair.
Caroline Martin, Governance Officer, supporting this meeting today.
Councillor Squire, Askinen Council Ward.
Councillor Mick Pritchard, Armthorpe.
Councillor Russell Inley, Hexthorpe and Bowby North.
Dr. Victor Joseph, Consultant in Public Health, Doncaster Council.
Morning, I'm Rachel Leslie, Director of Public Health at the Council.
Morning, I'm Sarah Smith, Public Health Improvement Coordinator for Suicide Prevention.
And I'm Sarah Atkinson, Public Health Improvement Coordinator for Sexual Health.
Cathy Wakefield, Principal Screening and Immunisation Manager, NHS England.
Scott Forbes, Enforcement Manager for Doncaster Council.
Matthew Julian, Senior Pollution Control Officer for Air Quality.
We've got colleagues who have just joined.
Apologies. Traffic. My name's Min Boyack. I'm IPC Nurse Consultant at DBTH.
Are there any apologies for absence?
Yes, apologies from Councillor Ken Guest and Martin Greenhalgh.
Thank you. There are no issues on the agenda which requires exclusion of the press and public. Declarations of interest. If you have any interest, please declare this on a form you will need to be completed following the meeting. Please contact governance team who can assist you with the process. Minutes of the Health and Social Care Overview and Scrutiny panel held on the 27th of November 2025, page 1 to 6. Do you agree this is a correct record? Are they agreed and are they seconded? Agreed. Thank you. There are no discussions on the minutes. I will allow 20 minutes for up to 5 people to speak, or 4 minutes per person in respect of matters within the committee's remit, proposing actions which may be considered or contribute towards a future development of the panel's work programme.
So
Right.
start speaking there.
Okay.
Is that okay?
Thank you. See. Good morning. Once again, I'm back. Pretty nervous. Been around in Doncaster 25 years, raising concerns of racism, only to be subjected to being ignored and victimised. But nevertheless, I owe a duty to my family and to people in Doncaster to keep on raising legitimate concerns. So I'm mindful of time, Chair, that I've got 4 minutes. So if you can just allow me to articulate what I want to say. Thank you. I need to be clear at the outset. The Health Protection Annual Report before us does not provide adequate racialised health protection assurance. That is not a presentational weakness. It is a governance failure. Under the Equality Act 2010, the Council has a statutory duty to demonstrate due regard to racial equality in the exercise of its public health functions. That duty requires evidence, not generalised statements of commitment. This report does not provide that evidence. Let me be specific. Emergency preparedness. We learnt during COVID-19 that racialised minorities community experience disproportionate mortality and occupational exposure. Where in this report is the ethnicity disaggregated risk modelling informing our major incident planning? If it does not exist, then we are repeating the very blind spots that cost lives. Infection prevention and control. There is no routine reporting here on infection impact by ethnicity. If we are not measuring differential risks, then we are choosing not to see it. This is not resilience. That is institutional complacency. Air quality. Environmental exposure is patterned by deprivation and race. That is a matter of national evidence. Where is Doncaster's local analysis of who breathes the worst air? If we cannot answer that question, we cannot claim equitable environmental health protection. Sexual and reproductive health. Black women nationally are significantly more likely to die in pregnancy. Where is our local ethnicity analysis of maternal outcomes, STI prevalence and access to contraception? If this council cannot demonstrate oversight in this area, that represents a serious assurance risk. Substance misuse. Do we know who accesses treatment? Who drops out? Who is criminalised by ethnicity? If we do not routinely interrogate that data, then inequality becomes structurally embedded. Suicide prevention. Suicide data that is not analysed by ethnicity is incomplete data. Prevention strategies that are not culturally informed are partial strategies. The absence of evidence here is deeply concerning. Immunisation and screening, uptake disparity are well documented nationally. Where is our ethnicity disaggregated data? Where are the targeted engagement plans? Where is the accountability? The core issues, this is not about intent, it's about assurance. Without differential analysis, dashboards and named executive accountability, this council cannot reasonably assert compliance with the public sector equality duty. And given Doncaster's shocking history in relation to race equality, dealing with race equality concerns, Professor Gus John, the BME Health Needs Assessment 2017, that gap is not neutral. It carries reputational and legal risk. So my direct challenge, I'm therefore asking, Chair, that for clarity on who is the accountable senior officer for racialised health protection assurance. When will ethnicity...
Thank you, sir.
Sorry, I've got two little points. I've just got 2 points. Thank you.
Okay.
Thank you, Chair. Tell her I'm a bit nervous. I'm not used to speaking in front of such a distinguished audience, so please forgive me, but I've just got 2 points. So that was the first point. The second one was, when will ethnicity disaggregated dashboards be presented to this board and to interested members of the public? And then thirdly, will a formal deep dive review be commissioned within the next quarter? Thank you very much.
Thank you for that. It will be noted.
Thank you, Mr. Brown, for your questions and comments. You'll see in a moment the presentation from the Health Protection Group. As a public health function, the local authority, we've got a convening and an assurance role. I did say to you at our agenda planning session a couple of weeks ago that I was really conscious that this was a really long report that covers lots and lots of areas, and that as a scrutiny committee you might want to consider how you want to receive the report, in what format next year. It could be, I can tell that there will be people here that are itching to answer parts of Mr. Brown's questions. We do have data recorded and analysed by different ethnic groups. We have got separate action plans for other minoritised groups in communities. We have got focused workers that work with different groups of people across each of these areas. We did review the findings that we had post-COVID around the vaccination schemes that we were able to run differently, and the impact and the difference that they made, and we have fed that into our plans. So I know people will be itching to bring the evidence and the examples of that forward. It might be, as a scrutiny committee, that you choose, when we prepare for next year's health protection report, to take a particular focus over each of these areas that we look at. So you might say to us as a scrutiny committee, you'd like to understand some of the areas that Mr. Brown has brought forward today. All of this work happens. It happens in the landscape and the many parts of the system that are operating and we as a health protection, or Victor as a health protection assurance group, brings together all the parts of those systems, and we put this, although it's still a nearly 50-page report, it is an overview summary of everything that's happened in the last year. Thanks, Chair.
Yeah, if I can add, thank you, team, for your question. We do have an action plan around improving health of minority groups, and it's fairly detailed. One of the theme areas is about data. We were conscious about the issue about how to profile a health outcome by ethnicity, and we have got a task working group set up to look into that more in detail. As Rachel said, during COVID, this was an important area. We work since, and we work to ensure that uptake and information reach out to the diverse community. And as a result of that, some aspect of the data around vaccination uptake, particularly around things like COVID, we ensure that ethnicity profile is part of that. And until now, that element is maintained by ICB colleagues, and they keep sharing with us as well how the uptake of vaccination, particularly flu, COVID, how it's going on, and what the profile also looks like. We'd want to see that embedded widely. There are system challenges and so forth, but we're working on that.
Thank you, Victor, and thank you, Rachel. I would like to introduce the officers to provide a short overview of the report. Thank you.
Thank you, Chair. So Victor has got a set of slides that he'll run through again, that journey of all the different areas of health protection that we present today. As I've just mentioned, so local authorities have a convening and assurance role around health protection. We adopted that since we moved over 2013, so 12 years ago, more than that now, it's coming up quite. And we've kept this process of bringing a health protection summary report to Scrutiny to tell the story of what's happened. So we select all of these areas, and I will invite you as a committee as well, maybe with some of that reflection towards the end of the session of what kind of report would you like in the future. But I'll hand over to Victor to present the presentation.
Health protection, as Rachel said, there was a law, Health and Care Act 2012. That was the basis upon which the functions of public health moved from the NHS, which was at the time Primary Care Trust, to the local authority. So we were the first to move to the council just before 2013 to embed in this new building here. And part of this, the collective work we did across South Yorkshire was to kind of answer the question, what does health protection system look like? We convened a workshop across all the partners in South Yorkshire, health protection, public health lead, to try to answer that question. And so I'll talk a little bit more on that. Part of also the Health and Social Care Act, what it did was to give that responsibility for health protection, with Director of Public Health having that overall responsibility. But it's not only one agency. The function of the health protection cuts across various agencies. And the other point to kind of mention is that, sorry, it's gone off there, that the system of health protection, okay, I'll go back, okay, yeah. So since 2013, we have a system in place to provide assurance to the Health and Wellbeing Board, but also to the Scrutiny panel, and we've been doing that every year. The stakeholders have evolved over time. So when health protection Health Assurance Group was established, the system then, some organizations have since been abandoned. Some new ones have been formed, but our current system still remain valid. So most of those organizations, either they've been abolished or new ones have taken up their place. So we have the local authorities that remain a key partner, not only public health, but there are directorates within the local authority that have got stake on this. For example, our colleagues, Air Quality, for example, they're a key part of our health protection system. We've got NHS England. We expect that to change as well as part of the current reorganization, but we still will continue to ensure that they are part of a local system wherever they move to. And the UK Health Security Agency, this is a new body that has been created. Its predecessor, you remember Public Health England. Before that, you have Health Protection Agency. Our local hospital are a key part of our system, including primary care, GP services, and so forth. There are other services that may not sit exactly in the hospital or primary care, like, for example, sexual health services provider currently, and others that are relevant. So that's kind of our health protection system. We agreed what health protection scope would look like. And obviously this is about, health protection is about ensuring that we have system in place to address infections, control infection in our community, but also environmental incident, major outbreaks, and so forth. So we do have emergency preparedness, resilience, and response as key part of that scope. Infection prevention control, air quality, sexual health, substance misuse, suicide prevention, immunization and screening. And colleagues around here are part of that scope later when we start to discuss key aspects of those 11. Now, just for each one of these slides, I've just kind of wanted to kind of pick up the key points just to kind of highlight what are the key things we need to kind of remind ourselves on. Emergency preparedness and resilience, key aspect of it is really to help us to prepare. We know the experience of COVID, and it's just important, just we need to prepare what the next either pandemic or major incident will come around. So they are the body that helps kind of make sure that we have plan in place, and test them by simulating if something happen. Are we ready? Is our system ready? And because of that, last year we were able to undertake at least 2 major exercises. One is simulating that if we have flu pandemic, our evidence suggests that it tends to be 50, 60 years you have cycle of pandemic flu, and they're horrible. We're talking about millions of people dying. Exercise Pegasus is another one which we had. This is simulating a new type of virus that kind of emerges, which we need to handle. So through that exercise, our team in Doncaster system came together to kind of work on that and see how to respond. And across South Yorkshire, we fed together to learn the lesson that we need to build into our system as part of that resilience. So again, there are a number of things there as part of that. The challenges, usually they tend to have aspect of inequality because there are people who are more affected than others. We need to be conscious about that. It's also our control mechanisms, our command and control processes. Through that processes, we've learned lessons, what we need to do. For example, what you see there, FFP3 is basically PPE, which is of a quality that and protect people who will be facing patients with infectious diseases. Issues to do with business planning and maintaining organizational memory. What happens is when these things happen, people in the system, they leak out or they go away, and the new people who come probably will have little memory what has happened and what need to happen. What needs to, if anything occurs, how can they respond? So as an organization, that's something that we need to kind of pick up, how we can be able to continue telling the story of lesson learned and retrieving that information fairly easily is a key part of it. Data is another important thing. They need to establish data cell, and from the exercise around the exercise Pegasus, we also learn, because it's simulation about the issue about pet and rats and so forth. Pest control is an important thing. When we do have major incidents, sometimes there are casualties and so forth. How do we provide those psychological support? So that's an aspect of learning we have picked up. And at the bottom of it, you see the public health incident management team. So there are various kind of incidents or outbreaks that happen, and we are continuously on top of that on daily basis, on weekly basis as well. We are in touch with our system. For example, the Health Protection, UK Health Protection Agency will let us know what we need to know on daily basis. Weekly, we do have our Health Protection Task Force. We look at what are the hot issues in Doncaster and how we can respond to that. And if we needed to call incident management meeting or outbreak control meeting involving all those partners, we can do so at short notice. Infection prevention control, so there's three aspects of it. We have two hospitals. They have each their respective measures in place, but we have also a focus on infection prevention control in the community. So we're talking about care homes, for example. So this one is related to Rotherham, Doncaster, and South Humber NHS Trust. They've got good systems in place in terms of ensuring that people who go to hospital and they will, without any infection, and they pick up infection there, this is what we refer to as healthcare associated infection. It is fairly quite low. There are a number of infections they will monitor on. Some of those abbreviations you may remember, MRSA. It is a kind of bacteria that is kind of resistant to certain antibiotic. There are some of them are sensitive to certain antibiotic. So those levels remain low. A key part of the assurance is a regular system of audit. Audit is basically a tool for helping to learn what you set out to do and what you're achieving. If you're achieving, great, you continue doing it. If you're not achieving it, what can you do differently? Again, they have good systems in place there. They keep an eye on outbreak that's happening in the system, like COVID and flu. And we do have the quarterly health protection assurance group. Each one of them will report to us around what's going on for that particular quarter, what are the achievements and what are the challenges, and what are the priority going forward. So as you can see, there are things still, that audit is still continuing, reviewing MRSA infection or screening work, and aiming to maintain a low infection rate in others. Similarly, at DBTH, quite a lot of work going on. There are infections, obviously. You can see there are COVID and influenza. Some are patients who go from community to hospital with infection. And I think that's why it's important to ensure that there's a strong work in the community to control infection. But there are also similar reverse things that happen where people go to hospital without any infection and they pick infection there. So it's important to ensure that in both settings, the systems are robust to prevent infection. Some of the control measures are simple, cleaning, and we often forget about that, but it is important to ensure that the simple measures are very effective and how we ensure that they are embedded in the system. And then other measures for reducing harm and resistance for a range of bacteria, for example, Clostridium difficile, the common bacterial infection that causes diarrhea. Those measures need to continue, as well as the use of antibiotic, good use of antibiotic. It's really important. We find that it's not only Doncaster, but this is a national but also a global issue. The misuse of antibiotic is the biggest problem because we have got limited stock of antibiotic. If they become resistant, then they become ineffective when we have wounds and other infection that we need to treat them. So there's ongoing work on that, improving pathway around blood culture, and also working to reduce some of those resistant MRSA infection in the community, including things like E. coli. So there's kind of ongoing work on that. Regarding infection prevention control in the community, again, this is a great deal of work has gone into this. This is a system that has been set following the COVID. Before COVID, one of the responsibilities around IPC, or infection prevention control, transfer from NHS to the council. This is in the context of the community. At the time, 2013, our capacity was limited, but we kind of commissioned that back to the NHS to provide that, but the funding was limited. It could only afford us like one nurse to employ. And we quickly realized during pandemic, you can't rely on one person, it will just simply fail. So we had to kind of agree as a system in Doncaster to a model that is sustainable. And it's kind of worked well in terms of that sustainability and being able to respond effectively to services. You can see part of that is how the team respond to infection prevention and control in care homes. You can see lots of visits there. It's a good thing because there are aspects like education you see down there. Education is a key part of the prevention. Educating the staff in the care homes to ensure that they know what the policies are, they know what the procedures are. Similarly for things like outbreak and compliance, how to report those to the health protection agency, agency promptly, so that actions are undertaken. But our systems is fairly good because they have got regular contact. They will pick those things up early, and then therefore actions are undertaken and in terms of control. Air quality, again, very important one. Due to this is something nationally. The bottom slide helps us to understand the impact of air quality in our population. Among people we refer to as premature deaths, so deaths that occur before the age of 75. There are about 50 deaths estimated in Doncaster due to air pollution. And if we take all age deaths, that's deaths that occur regardless of any age, so about 150 based on the figure of 2023. So key thing here is, yes, it's important to, there are a lot of work that's going on, and our colleagues in air quality will kind of expand on that in due course around a number of work that is going on to kind of to ensure that our identified area comply with the air quality measures that is kind of agreed nationally, and their monitoring systems are also in place. Again, sexual health, key things to kind of highlight there is we have got the systems in place to be able to provide effective sexual health services, which include, among other things, obviously picking up, identifying cases early, and ensuring we have measures where there are, for example, emerging preventive measures like vaccination. We kind of reach that out. A key aspect of it is we've been monitoring the rates of syphilis in our population. And over the past 2 years, we have been working hard with our system partners to ensure that we understand what is going on. One of the issues with syphilis is it presents in such a way that a lot of people may miss it because they are such a way that they could affect all parts of organ, particularly at complicated stage, but even acute stage, they can present with any kind of skin condition. Clinician would miss it. And so one of the work we've done was about communication with clinicians as well to raise awareness, but also for our public as well. And that work is still ongoing. Substance misuse, again, a great deal of work has been undertaken by our colleagues within public health and with our partners as well, our commissioning partners, to try to address the challenges presented with substance misuse. So risk is a big, how we address the challenge of risk of death and infection, particularly emerging products and so forth, are big issues. Suicide, again, key thing to highlight here is the figures seem to be kind of decreasing, but still remain a very important issue. Each death is associated with a lot of tragic implication to the close families and communities and friends of those that are affected. There are systems in place in terms of, for example, you can see the training that are in place to make people more aware. Screening program, there are a range of screening programs, and looking through the dashboard, I think our performance is similar or near to kind of the national average. There are challenges, but they are kind of being tackled in terms of that quality assurance, and our colleagues might be able to add something on that line later. Again, immunizations, very important, because they straddle all ages, from childhood, adults, and older people as well. So you can see a range of them there. We do have also vaccination cells locally to try to kind of keep on top of how we are doing with vaccination. We are conscious that some of these challenges are not only for Doncaster, but they are national challenges. For example, taking conditions such as measles, mumps, and rubella, to achieve protection, you need to get 95% protection of the population in terms of preventing things like outbreak and so forth. But some of the challenges getting there is quite challenging. And as I was saying, not only for Doncaster, but in England as well. But our performance is, we're keeping an eye on it, and it's improving. And in summary, what I'll say is we have effective health protection system in place to protect the people of Doncaster. This has been established fairly more than a decade ago, following a robust discussion among system partners and what the scopes should be. We do acknowledge that there are challenges. Each of those areas, we do have colleagues around the table here who are leading subgroup and so forth. They're picking those challenges and are working on that. We do have system reorganization that poses a challenge. For example, we know ICB are reducing their capacity from what it is to 50%, and that's going to have impact in terms of how we work. It will take time for them to kind of settle before the reduced workforce now agree what they're going to work on. And I think that is something that we're keeping an eye as a risk to the system. That's the key highlight of the presentation. I'll hand over to you, Chair.
Thank you, Victor. That was a lovely presentation. I would like to now move on to questions. And on my list, we've got Councillor Squires.
Thank you, Chair. Good morning, everybody. My question, excuse me, can you explain a little about the Health Protection Assurance Group and how it is, or how it is ensuring that learning from incidents and outbreaks is systematically embedded across all partner organisations?
Thank you, Councillor Squire. So I think in the introduction we've given you some of the overview about the Health Protection Assurance Group, but just wanted to give some more detail about your question about how it systematically responds and learns from incidents. So I'd probably say there's kind of 3 layers and levels of learning. So Victor described about the national exercises, and we also undertake local exercises as well. So exercise Pegasus, we've had our own local exercise probably about 18 months ago around a measles outbreak. So we run that exercise and bring in all relevant partners, and then from that there would be an action plan that would either be supported by the Health Protection Assurance Group or would be overseen by, we've got a joint health and emergency planning group as well, and there are some subgroups that Victor will give some detail about as well to the health protection assurance group. So that's the kind of large-scale exercises for learning and embedding. Then the other approach is if we have an incident of any kind in Doncaster, then what we would usually do is a hot debrief. So everybody that's been involved in that response, kind of getting that learning off their chests and recorded as quickly as possible. And then we would usually, if it was indicated, have a more in-depth after-action review. So a set of questions that would go out to all stakeholders that were involved in that incident, and they would describe what went well, what didn't go so well, even better if type statements, and then we would have that as a set of learning again. It would sometimes be the health protection assurance group that would oversee that embedding, but usually is done through other systems. And then the other kind of more routine learning and applications would just be the teams and the functions going about their everyday business. So, for example, our infection prevention control services going around to care homes, observing, supporting, recommending. If they spot something that's happening that's a little bit different in a few places, then that's a new piece of learning to take across all of those different care homes. So that's that kind of dynamic routine type approach to learning and embedding. So I'd say there's those three kind of formal and informal approaches. Victor, I don't know if you want to add some more.
Yeah, maybe so. It's a good opportunity to give the context. There are two aspects of the question. One was just to explain a little bit more about the health protection assurance group. And then the second part of the question is about the learning from incident and outbreak, how it is embedded across the partner organization. So regarding the first one, health protection is part of the wider public health process. So public health is about helping people to live longer and preventing diseases. And the third element is about reducing health inequality. We do know that health outcomes are not the same across different population groups. So that still applies to health protection. We ensure that that it contributes to improving health, but also it also addresses the issue of inequality. Coming back to the second part of the question, in terms of the learning from incident and outbreak. So one big learning was following the COVID. As I was saying earlier, our infection prevention control system was not robust enough, partly because of the capacity issue. During the pandemic, that was immediately managed by the various partners contributing staff resource to kind of correspond to the outbreak, particularly in care homes and as well as in hospital. The hospital one, they manage it, but actually it is a kind of a loophole where if you don't manage the one in care home, it will feed into the hospital. So it was quickly realized that we better look at how we manage infection prevention control in care homes. So that helped, but what happened was immediately after COVID, most of those support mechanism was short-lived to respond to the pandemic. It was pulled back. So as commissioners with our ICB colleagues, well, it was not ICB, it was CCG, Clinical Commissioning Group, we came together to kind of agree on with our providers how we can put a sustainable model. And we agreed that we should have a team that will manage infection prevention control. That has been working well in terms of responding effectively to outbreak. And then the second point is our health protection assurance group, all the scope that I described there, has got sub-teams or groups that are working on it. For example, you have suicide prevention, you have got sexual health, and infection prevention control. There are steering group that kind of manages that. Within that element, there is a mechanism for ensuring that lessons learned are taken and embedded into the system. And the system here includes partners, providers, and so forth. Outbreak management, we do have a range of outbreaks that happen. As part of the standard process, we learn not only from that particular outbreak, how it has been managed, but also we also learn from similar outbreak in other places, because a good example is TB, tuberculosis. We do have complex situations where individuals refuse to comply to treatment, and we know from public health point of view that poses a serious risk to themselves because they could die, to their families, and to the public. So we need to kind of learn lesson. How far can you go? We have legislation to support us detaining somebody in a place of treatment, but that is the last resort, and we wouldn't want to kind of implement that as a first result. We have to try all other things. So that's the kind of thing we've learned from other places where they've taken to that level, where they've taken somebody to court to kind of a place of care. It is costly. So we have to kind of try all other means to be able to ensure that we support the individual to comply with treatment. We have got terms of reference in place, and part of that terms of reference also embed an aspect of how we can continue to learn from one another. I hope I've answered that question. If there is any question along that line, please let me know.
Thank you. Do you want to go on?
Since the COVID outbreak, and we're better understanding of it now, with the care homes, are staff well trained to spot the signs of it now? So if we get a patient that is showing signs of symptoms, are the staff well trained up so they can spot it, isolate it, and obviously go through the relevant the procedures to contain it? So are staff now, when nursing homes take them on, is that part of their training to understand that? That's one question on that.
Yeah, I'll take that question. Min Boyak from DBTH Infection Control, head of the team. Yeah, since COVID, everybody's awareness is heightened, and then we support the care home teams as well. So usually what happens is they'll give us a ring as soon as they have anybody with respiratory symptoms, and that either might be COVID or it might be flu or something like that. We will then deploy, my team will go out, within the next working day. We'll bring them tests to do, we'll support them in anything that they're not sure of, and then support them in managing that outbreak, whether it be COVID or flu or any other respiratory illness in terms of isolation and things like that. But we do that not just when something happens, so we're doing that all the time. So we have over 800 face-to-face visits, and that's where the strength of the service is, because actually if we're in their care homes, we're supporting them in their environment and problem solving to help them do the right thing, based on their setting and their context. So that's what we're doing all the time when we're visiting them, so that they know exactly what to do when they see anybody with symptoms, and they're straight on the phone to us. And you will see that we report quite a lot of outbreaks in the community. That's because the teams are on it straight away. So they're contacting us, and then they report to public health, even when there's 2 or 3 cases of a respiratory illness. So I think that's really embedded since COVID. We also do question and answer monthly sessions on Teams, so that everybody can join who wants to, and we'll talk about things that are current in response to any incidents or anything, any learning that might have come from an outbreak in another care home, so that we can bring everybody together and spread that learning out. So yeah, I'm confident since COVID.
Can I ask, what if there's a suspicion that somebody's got COVID-19? What's the steps they take? What's the first steps they take to isolate it? And because you've got influenza and COVID, the differential is they're similar, aren't they? So first of all, when they spot it, how quick are they to isolate that situation? I know you said you can come the following day, but the differentials between them both, somebody could have flu, somebody could have COVID. To isolate that, how quick would they do that immediately?
Yeah, they do that immediately. So they'll have already put that in place, and then they just let us know. And then if there's anything, so for example, like you say, the first step is they isolate that person in their room. But it might be that that person is confused, doesn't understand that they've got to stay in there, has other needs. So we learnt in COVID that a lot of our elderly people who have dementia, they eat taking social cues from other people. So when they were isolated in a room, they were not eating. So in those circumstances, yes, isolation first in the side room, in their own room, but it may be that that's having a detrimental effect on their health in other matters. So we'll go into the home, or to be honest, since COVID, we know the layouts of the homes. The homes know what we're going to tell them. So it'll be like, right, you've got 2 lounges. So those persons who look like they've got respiratory symptoms, who looks clinically like this is COVID or flu, we'll try and put them together in a different room and separate from those that don't have symptoms. So there's all different kind of things to consider, but they're on it really quickly. You know, they just are. And then they ring us to say, this is what we've done. We've got these people that have got respiratory symptoms, and we've done this. And we'll say, fabulous. We'll come out and see if there's anything else we need to do or anything else you could do. So they're pretty fabulous, really.
Are they taken from the home, or does the home contain it itself? So they're not sort of taken straight to hospital. They are contained in that home.
Yeah, it's their home, so they'll stay there unless they're clinically unwell. And then, it will be the same process for anybody. It will be GP called, and if that person needs admission, they come in. And then that's the beauty of our service as well, because we are in the hospital and outside the hospital, so we can then ring and say to accident emergency, you've got a patient coming in from this home where it looks like we've got a situation happening with COVID. Then immediately, as they cross the threshold, they're segregated from other people. So it works really well.
Right, thank you.
Thank you. We do have a supplementary from Councillor Carroll.
Hi, morning. Just going back to Councillor Squire's original question there, what training are they actually given to recognise what's involved in that?
So we'll do, when we go in face-to-face, we'll do sessions with them on what PPE to wear, how to isolate, hand washing. So we actually go into the homes, we take the light box, I don't know if you've ever seen that, where we'll show them how to wash their hands, and they look under the light to see how effective they are at washing their hands. So there's that kind of informal, but at the time kind of teaching or before actually in the home. But there's also a course that's facilitated by local authority with the support of our team as well. So we'll help facilitate sessions in a classroom where all that is gone through. So the basic standard precautions, which are put in place anywhere, any setting, hand washing, environmental cleaning, PPE, it's not relevant to this situation, but sharps handling, just the basic key things that we put in place to minimise the risk of infection. So there's the formal stuff going on in a classroom, and then there's the informal kind of us going in, assessing hand hygiene, teaching people at the time. A lot of the learning comes from problem solving within that environment, from us going and seeing what their challenges are and helping them put things in place to minimise the risk of infection in their setting specifically.
So what training are they given to be able to recognise the symptoms or the difference in the symptoms?
Well, in terms of respiratory illness, so we'll tell them what symptoms they're looking for, and it's the same, whether it's COVID, flu or any other acute respiratory illness. You've got residents that are coughing, got cold and flu-like symptoms. As soon as they recognise that, they'll give us a ring. Or they'll, if the person needs to, they'll be ringing the GP.
Okay, thank you.
And the next question's mine. This is emergency being prepared. In your plan, you're looking at this being approved by the Joint Health Emergency Planning Group early 26. Could you advise when in 2026, and will this still have quarterly meetings going forward to update when needed?
Yep, so that's me, and it's the multi-agency outbreak plan that you're referring to. So I chair for Doncaster the Joint Health Emergency Planning Group. The meeting to approve that plan is on the 18th of March, and yes, that group meets quarterly as well. What we have is a plan log, so all of the plans that that group is responsible for or feeds into is kept as a plan log, and it says when it was last updated, any updates made, and then when it's next to be revised. So we kind of keep a bit of a rolling programme for that. And sometimes when we know we have to make amendments to it, so we've updated quite recently an adverse weather plan as well with all the public health and health protection response to those elements. So if one of those is released nationally, then we will review our local plan more quickly to enable us to put those things in. So we meet quarterly. I would say that there's, in terms of my role around health protection and public health assurance, so some of the partners with that, we've got our emergency planning colleagues, we've got colleagues at the hospital at RDASH that are involved in emergency planning, and then we've also got the ICB, so the Integrated Care Board, our local NHS kind of organising body, who should be a Category 1 responder for health protection matters. We know Victor's mentioned earlier that we've got some changes happening with our ICB makeup, so I would express to you that we might not have as much ICP input over the next probably couple of meetings as those changes happen. Thanks, Chair.
Thank you. And next we have regarding infection and prevention and control, Councillor Linley. If you have any supplementary questions, if you put your hand, just raise your hand. Okay.
Oh, you've got supplementary?
No.
That's up to you. Hi all. Yes. It's on. I'm just speaking very quietly. Spread of infection. Did you find during 2025 with 272 patients cared for who have tested positive to influenza, 351 patients with COVID-19, 2 outbreaks of norovirus, whatever it is, yes, and 1 outbreak of COVID-19 is much lower than in 2024. And just as a bit of an addendum to that, if you like, talking about outbreaks, compared to 272 patients testing positive, there's 2 outbreaks of norovirus and 1 outbreak. What actually constitutes an outbreak in terms of numbers? Is it 1? Is it 10? 100? And then the second part of the question, if you like, is notice that in older persons' care homes environments, learning disability environments and supportive living environment audits have detailed they are going in the right direction. And can this be verified, and how is this addressed through CQC reports, please?
So can I do a little bit of intro to that, and then Mim will come in on some of the details. So I was dead excited to answer your exam question, which what constitutes an outbreak. So it's any 2 or more cases associated in person, time or place, but Mim will give you the detail to that as well. Just on flu numbers, particularly flu numbers for this year, and I'll mention the other respiratory illnesses as well. There was quite a lot of excitement November, December time about us having, I can't remember, mega flu bomb. Just wanted to take this opportunity to say that the numbers show that wasn't the case, and I'll tell you for why. So flu, we always expect to see an increase in cases as we get to the winter period. This year we had something different. So we had point of care testing, which we've not had before. So previously, if you were on a ward and you suspected that one of your patients might have flu, then you would take a swab, take a sample, send it off. This year we've had point of care testing. So nationally, flu numbers have looked higher because more people have been tested. However, they were weren't out of range to show that it was a particularly high flu season. There was a little bit of concern because obviously you don't know what's going to happen week after week. So there were all those plans to put extra things in place just in case. But just to bring back to the facts and the data, it wasn't a mega flu season. It was an as expected flu season. And to take that opportunity again to say it's so important to take your opportunity for a flu vaccination. If you're eligible for one, then that will provide you with that protection. If you're not, then there's opportunities to get vaccinated for not much money at all. COVID is really interesting in that we haven't quite worked out what the pattern of COVID is. So we expected it, I think, to be a similar kind of winter virus. So when everybody gets cold, congregates inside, breathes on each other, then that's when you get your cases. But it's actually had more of a kind of a wiggly pattern. So it doesn't seem to have any seasonal element to it. So we actually went into the winter period with really low numbers of COVID. So just wanted to take that opportunity to kind of dispel the myth that we didn't have a flu bomb, mega flu season. We had a normal flu related season and that chance to talk about flu vaccination again. But Min will check my homework on definition of outbreak.
Yes, stole my thunder. It's, two or more cases linked in time and place and organism. So it might be diarrhea or it might be respiratory virus or something like that. Yeah. In terms of COVID and flu numbers, in terms of 2024, we were slightly up 2025, but then there's like Rachel was saying, there's so much variation. And if we go back to the year before, we were on COVID 295 cases, 164 flu cases, but the year before that, of course, we were on thousands of COVID and flu cases. So there's variation year on year. And in terms of the outbreaks, so in 2025 we had 2 norovirus outbreaks, 1 COVID. The year before, 2 norovirus outbreaks, 3 COVID. So pretty level in terms of outbreaks, which is not too bad. We don't tend to have too many outbreaks in hospital compared to some other organisations, some other regions. But there's so many different factors involved in how that's contracted and how that evolves, which I'm happy to go into, but I might be here all day. But, if you've got any supplementary questions, I'm happy to take those.
Right. Supplementary questions. Care homes. Now, I'm going back to the original COVID outbreak, which was slightly more than 2. While I was actually doing my work as a boiler engineer, I found that care homes were the places that were most desperate really for the services of engineers to keep places going, particularly if it was the only source of heat they'd got. Enjoying my trips out, I noticed that basically the care homes particularly were locked down, nobody allowed in, nobody allowed out necessarily, like deliveries were left at the door. I was not actually allowed inside because, well, basically the boiler house was outside, so I didn't need to go in. So to my mind, care homes were the least likely places to be suffering from an outbreak of COVID, as it was, because they were basically isolated inside the building. They got the care givers that were required. They got all the cleaning mechanisms and medicinals, etc. So basically they were isolated in their own little bubble. They weren't even allowed visitors. So surely these people were among the most protected of the population. And yet they were suffering some of the most damaging outbreaks, if you like. So what is the lesson learned from that? Because, as I say, to my mind, if these were the most protected people and isolated people from the rest of the population, what chance have we got if they were suffering the losses like they were? I know they were older, they were more vulnerable, frail, so they're less likely to be able to resist all these problems. But there's got to be an immense learning curve there to make sure that if COVID, in whatever guise it is, can get into a place like that, what are you going to do for the rest of the population?
So I think older people were a more vulnerable group by definition. So you might remember, and for some of us this will be flashbacks, that there was a case definition of a vulnerable person. So also people with particular disabilities and of particular age groups were described as vulnerable population, and had things like shielding applied to them as well. It's important to say in planning for emergency planning to not assume that the most vulnerable group will always be the same vulnerable group, but there probably will be some that are more vulnerable. An example is the recent exercise Pegasus that Victor mentioned, completely fictional, but worked on the principle that it was children and younger people that were most likely to be affected. So, and as with any new novel virus, novel infection, we won't know straight away who's most vulnerable to it, and it might be a bit of an iterative understanding. As Mr. Brown said in his introduction as well, we found that people from black and minority ethnic groups were higher risk, probably because they still worked in some of the industries where they were required to be present at work, or for some communities it was because they lived in overcrowded places. So we must keep ourselves, in terms of the learning that you've asked about, we must not think that our older people will always be the vulnerable group. They usually and probably will be, and that's why we have vaccination schemes. So again, another chance to plug vaccination. A lot of the things that can make people very poorly, there are vaccinations for, so that will protect that community. And then just to describe that bit that you said, oh, if we can get infection into care homes, then the risk is everywhere. Each of those workers that worked there also had homes and families probably to return to each day, and also had tasks that they needed to complete. And even where they were following all of the guidance at the time, the 2 metre distancing, the face coverings, all of those things, it was such a nifty virus, wasn't it, that we saw it break through significant safeguards put in place. So yes, you're right, it should be the most safe environments, and for many times, in many cases it was. But yeah, just that bit about learning, in that we just need to be careful not to think that whoever was described as a vulnerable group last time will always be. Mim, I don't know if you want to add.
Just add to what Rachel has said, really. I think the biggest learning curve was that nobody is protected completely. When we think about the time where everybody was shut down, you couldn't get in the care homes, that was more or less at the beginning or in the early stages of COVID, when nobody could go in. We didn't have the testing that we had later on. There was no LFT testing until later on. We didn't have the COVID vaccine. So all those things heighten the risk of any cross-infection. And like Rachel said, the staff were going home each day. So they were, travelling, having families who were out, all that kind of thing. And that's how it was getting in really into the care homes. And the incubation period was changing. So if you remember the variants as they came along, at the beginning the incubation period was thought to be 8 days, then it went to 7 days, then it went to 14 days, then it went back down to 5 days. It was, it was really changing all the time. So you could have somebody who was exposed. So if I caught COVID today, I was exposed to it today, my body would be cooking it. I wouldn't know until however long, 5 days, 10 days later, until I started with symptoms. But actually, the thoughts were that we were actually infected 2 days before we had symptoms. So you couldn't even say, right, well, I'm not going to work today because I've got symptoms, because you were infected 2 days before, and don't know what you don't know. So there's so many variables involved. It was a really difficult time for everybody. And I guess the really good thing about that is we recognise the impact that all the lockdowns had, and do things a bit differently now.
Right. Can you hear me better now? Just anecdotally then, throughout the early COVID years and COVID-19, I never felt better in my life. Probably because I was isolated from everybody. I just stayed in, didn't go out. Nothing to do, so I was feeling great. The worst time of my life was when I had my first COVID jab. Okay, and I, putting it bluntly, I thought I was on my deathbed. And it wasn't man flu, I was seriously bad. Now, that was me responding, if you like, to that jab. And I was, for my age, I was pretty fit at the time. Now, I'm concerned that when you have vulnerable people who are isolated in a place, such as care homes or wherever, and they're subjected to basically untried, untested serum as such like COVID antivirus, whatever you want to call it. What guarantees are we going to get, if we can get any, that a situation isn't going to arise where they are the first people, the most vulnerable people who were in the most protected areas, if you like, are actually getting the first treatments of untried and untested serum. It didn't seem to work very well to me, to be honest.
We've got our colleagues here that can answer that question for you, but every vaccination that we use in this country goes through rigorous processes and approved by JCVI. I've got that the right way around there. So I'll just hand over. Do you want to explain?
Yeah, thank you. So obviously normally any medicine, whether it's a vaccine or any other medication, goes through a strict process of trials, licensing, testing, etc. In the UK, we have the Medical Health, MHRA, Medicines Healthcare Regulatory Authority, that is responsible for authorising all medications. From a vaccine point of view, Rachel mentioned the JCVI, which is the Joint Committee for Vaccination and Immunisation. Again, their role is looking at evidence of infection rates, evidence of impact of vaccination on quality of life, length of life, etc. And they make that recommendation. So it's a combined process between JCVI and MHRA. With the COVID vaccines, because we were in an unprecedented pandemic situation, the same processes applied, they were just speeded up. So it wasn't that they were untested, it wasn't that they were unlicensed, they just didn't go through that prolonged period. So the same principles were applied, it was just a condensed timescale that happened. Obviously, we've had COVID vaccination for several years now. Uptake varies from season to season. We've got a spring programme coming up starting in April. We work closely with our social care colleagues and our local authority colleagues to promote vaccination, particularly in care homes. And over autumn, winter, South Yorkshire have done well at achieving a high uptake within care homes. So it's not that the vaccines aren't tested, it was just an expedited process, but it went through the same principles. And as Rachel said before, in terms of the pattern of COVID, because we're not seeing that seasonal pattern that we get with flu, is why we're still kind of going on a season by season, year by year review by JCVI, and we've still got the spring campaign, we've got the autumn winter campaign, but the cohorts have been significantly adjusted again to make sure that it targets the most vulnerable and has the highest impact in terms of reducing the level of illness in those individuals should they contract it.
Thank you for that answer.
Thank you, but I understand what you're saying, but we're always playing catch up with such things as COVID-1, COVID-2, COVID-9, and we're always working on last year's version. So, what have we got in so we can actually anticipate the next round of virus attack?
So in terms of flu viruses, they're developed based on what's happening in the Southern Hemisphere, because that's a good indication of what will happen in the Northern Hemisphere the following season, because they're a season ahead of us in terms of their winter season. So that's the kind of general marker for UK developed and European developed vaccines. In terms of COVID vaccines, again, yeah, it's based on kind of the strain that's circulating at the time. This autumn winter, there was a slight shift in that virus, but again, the vaccine that we'd got, that we were using through autumn winter, was still found to be effective for that vaccine, even though it was a new strain. So I think we don't get too hung up on whether it's a JN1 or a JN92 or an HB5. It's looking at how effective that vaccine is against that particular strain. Respiratory viruses particularly mutate and change on a highly regular basis, and we might want to say more on that. And that's the reason that we have an annual flu vaccination programme, because of the way that those respiratory viruses change. COVID viruses are no different to that. And again, the UK Health Security Agency are working with NHS England, working with JCVI to constantly review what strains are coming through, what strains are circulating, what vaccines we've got, how well matched they are, and whether there needs to be any adjustment. So it's an ongoing, continual assessment process.
I'd like to thank you for that.
Is it okay to ask a question, Chair?
Can we leave it till the end? Because we do have a lot more questions to go through.
To this. It is relevant to this subject.
Okay.
The spread of infection. My own personal experience visiting a nursing home, and just bring it to your attention. On 2 occasions that I visited a nursing home. I won't name the nursing home. And basically, on my first visit, I noticed the patients walking about unsupervised, and I could smell that probably the patient had done a mess. Nobody there. So it concerned me a little bit that this person wasn't looked after properly. Now, she probably could have been, but it continued on my second visit. But on my second visit, which was in a short period of time, we was warned before we went in. It was there was a diarrhea sickness bug. We had to wear face masks. So I started to think, well, is this nursing home making sure it's hygienic? And I would have thought on my second visit that I would have probably smelt the change in the smell of on the first visit, and I would have thought it'd have been more cleaner. Do you get what I mean? You know, when we have bugs and things, it's disinfected. I proceeded to go to the room, to the person I was visiting, and again I witnessed the person was asleep, didn't disturb her, but there was food, bits of food, what had been left on a tray that she'd consequently had for dinner. So the tray weren't clean. Again, a very strong smell of that, the poo, if you like, to put it commonly, and I could smell it. And it concerns me that if I can smell it, the staff can smell it, there's a spread of diarrhea and sickness on in that home, I would have expected something different to what I witnessed. Does that make sense to you? I would have expected a smell of disinfectant. I wouldn't have expected the smell of what I smelt in the room. I wouldn't have expected food left on trays. So, and it goes back to if we've got a diarrhea and sickness bugs, our staff trained up to deal with that. And really, looking back, it probably wouldn't have been in my interest to go in. We were allowed in. So I didn't feel in that it was contained. It wasn't dealt with properly.
So if you are ever concerned about any of the care homes in Doncaster, there is a route to express that. We've got a quality team that's part of Phil Holmes's team, not here today, but that can address that and look into that as well. I can speak just generally. So CQC, Care Quality Commission, do include things like infection prevention control in part of their inspections. And overall, we've had some in Doncaster really good inspection results from many of our care homes. But if anyone ever that's you in your elected member role, or any resident, anybody visiting a care home is ever concerned, then do come through the council's customer services route, and we've got a quality team that can check in on that as well.
Yes.
Thank you.
Sorry, Chair. Just as I say, I think when you've got an outbreak of diarrhea and sickness, I'm sure it's standardisation throughout nursing homes. When you've got that, isolate it, clean it, and make it stop the infection, stop the bug. I didn't witness any of that. So, I mean, I don't want to really make reports about it. There probably might have been on the 2 occasions I've been there. But I think it's something that when there is an outbreak like that, visiting for me, visiting shouldn't have been allowed. They should have contained it better and looked after it better. Going back to the other one, and I'll make it quick, Chair, immunisation, flu vaccines, we give it to the over 60s, is it? And people with health issues. How many people do get off sick through industry because we don't give it throughout the age groups for free? Because some people, if they know they've got to pay even a few quid, won't have it done. Would it be wise to have it free for everybody?
So again, colleagues might come in. The cohorts can change on occasion. So flu vaccination itself, pregnant women also are eligible, and there's a programme for children all the way from age 2 to 3 as well. So that the principle of vaccination in children is because they're probably a bit more grubby and more likely to spread the infection. So that's to reduce that community spread. We as a nation operate on the resources that we've got available to us. So there's something about for what we've got available to us. And this is vast scale of vaccinations available. So there's all the generation of them and the circulation of them, keeping them cold, getting them into people's arms or up people's noses as well. So generally, we would recommend vaccination for the people who are most at risk. Do you want to come in as well?
Yeah, thanks, Rachel. So again, this is the work of the National Joint Committee for Vaccination and Immunisation. So again, it goes back to them assessing the infection, the impact of that infection, which groups are most likely to be affected, which groups are most likely to be impacted by serious illness, complications, and or death. Rachel mentioned the young children. Young children were introduced kind of over 10 years ago, and that's because they are super spreaders. So they may be asymptomatic, but still spread into those vulnerable populations. As Rachel alluded to, we, as all elements of healthcare, are limited in terms of resources, in terms of the number of vaccines that we've got available to us. These vaccines are manufactured for across the whole of the Northern Hemisphere, not just the UK. So there isn't an infinite supply of vaccines for everybody. It's not cost effective to vaccinate everybody because the majority of those cohorts that are not included in those vaccination cohorts will have are considered to have a minimal impact. That's not to say that the odd one won't have a more serious impact from that infection, but generally that's part of the assessment. the other purpose of vaccination. And again, in terms of resources, our healthcare system, whether it be community pharmacy, whether it be GPs, hospitals, could not cope with vaccinating every individual in the UK. It's just not realistic to do that. But what we work on is a principle of herd immunity or community immunity. So if we get high vaccination numbers in those cohorts that are those groups that are recommended by the JCVI, then the people that are not vaccinated or don't take up vaccination or can't be vaccinated for medical reasons will be protected, because it's breaking that chain of infection. If you don't catch it, you can't pass it on. So we work on that principle. We vaccinate the most vulnerable, but by doing that, we protect the ones that are not vaccinated.
Thank you. The next question is mine. It's regarding air quality. Is this still an ongoing issue, as we are aware that there's more houses being built, there's more people moving to Doncaster and more cars on the road? What are your future plans on this?
Yeah, I'll just come in first. Excellent question. So basically, obviously, air pollution is a major issue that we're trying to tackle. So just to start, basically, when you look at the planning aspect of it, so when they are looking at a new development, obviously anything with 8 units or more, developer needs to submit a travel plan with their application. There's also potentially the requirement for a traffic assessment, which will it'll look at the impact of the actual development and the traffic in the area. With any planning application, there's a series of consultants. So all those consultants will sit down and look at everything, and then obviously get together and take on board whether it's going to have effect. We look at that as well, so we look at it from an air pollution aspect. We try to figure out the area that it's in. So what we do constantly throughout the year, which I'll let Matt explain just briefly shortly, is we constantly monitor the air quality in Doncaster. So we're aware of the areas that have higher levels and those areas that are lower levels, and we can assess that impact in that specific area to see if it's going to actually have an issue. We have in the past, if we disagree with it and we feel that it will cause an issue to that area, we will say that in the planning application and state that we don't think that the development is probably right for the area due to pollution. So there's lots of teams of consultants. I mean, we've got obviously the highways team, we've got the active transport team, we've got ourselves as Clean Air. And then obviously there's other factors as well now. The increase of electric vehicles, hybrid vehicles are starting to reduce pollution levels as well. Even transporting fleet have now taken on board the issue, and they're looking at better vehicles with regards to HGVs. So there's lots of things that are taking place looking at the entire air pollution within Doncaster. Just going back to how we monitor, I'll just let Matt explain, because what Matt does as our expert, we constantly monitor, we get all the results, we look at the entire area of Doncaster, and then we release what's known as an annual strategy report, which also looks at all those factors and again gets all those consultants involved to look at what we can do with regards to the air quality in Doncaster. So Matt, if you just briefly want to explain about how we do the monitoring.
Yeah, so we have 2 ways of monitoring. We have continuous monitoring labs, which are calibrated, they're serviced, they're maintained. These are located in our worst areas, our air quality management areas, and they give us the most accurate results. From there, to be able to cover a wider area, we have diffusion tubes, which are a low-cost option that we can deploy to areas where maybe we've had a complaint from a resident or similar, or just areas where we know there's busy roads, schools, whatever we want to target, we can put out those diffusion tubes. The problem with those is that we get a monthly report of what those levels were over those months, so we can't target specific rush hours or any particular events like we can with the continuous monitoring. They're more cost effective. The way we address air quality is twofold. As Scott mentioned, we're a consultee for planning, so from that approach we're trying to stop air quality getting worse. Every planning application that comes through is assessed against our technical planning guidance that we've brought in. That's on our website for developers to look at the requirements, what they're going to need. That will break down those developments into size, so minor, medium or major. They will then have specific requirements for doing assessments, whether that's an air quality assessment, which will then require damage costs to be attributed to that development. that will then give us a monetary value to put against mitigation measures so that we can then offset the emissions from those developments, whether that's cycling, storage for the properties, electric charge points, low emission boilers. These are sort of the measures that have been suggested by developers, and that stops and hopefully prevents areas getting worse by new developments coming forward. The second approach is through the monitoring and the air quality management areas. That's where we know there's an exceedance of the objectives, and we've declared an area, an AQMA, an air quality management area, where we need to then focus our attention on. From there, we need to produce an air quality action plan, which then brings forward measures that we're then going to implement or look to implement to address that exceedance in that area. So that's the sort of two ways we go at it, but it is an ongoing issue. And even though we're going to be revoking 4 air quality management areas, we will continue to monitor in those areas, and we'll continue to work to make sure it doesn't get worse.
Thank you for that answer. Very complex. Keep up the good work. We've only got time for one extra question because we've got to move on. Time's moving away and we've still got a lot of questions.
Would you say roadworks is a contributory factor to air pollution? What I'm meaning is we have a lot of roadworks going off. There's one in particular that I get stuck in quite regularly. And then shortly after that, you've got another roadworks. Then you've got, through 2 roadworks, you've got to build up a traffic. Would you say that can contribute to making air pollution? Being stuck in traffic, engines running, bad planning, and I will say it's bad planning, because when they look at it, somebody puts a roadwork on. Sometimes they're working on it, sometimes not, but the cars are stuck there. The air's getting polluted, and from my point of view, and I'm sure it's for a lot of yous, when you're stuck in roadworks, it's not necessary. When they look at doing roadworks, I think to prevent some air pollution is look at putting one job on, getting it complete, then putting another job on once that's completed, rather than a big congested build-up, and then by the time you get to Doncaster, you've got coming over St George's Bridge, you've got a right build-up of traffic coming from York Road, from A19, and there'll be other areas. So I think that when we look at air pollution, having vehicles stop for a long period of time at these roadworks and continuous roadworks isn't helping the matter.
So I think it's probably beyond the scope of this scrutiny committee and those that have joined to be able to answer you comprehensively on that. Congestion does cause issues, and probably the one that we can explain to you is around school streets as well. So we know that there's points of congestion at the start of the day and at the end of the day as well that could be particularly risky to young lungs and children who are actually walking lower to the ground where all of that accumulates. And we have had things like school streets programmes as well. And I won't miss the opportunity to talk about active transport. So walking, wheeling, cycling, you'll remember we came to speak to you about last time we got together as a scrutiny committee. So another way of getting more cars, more polluting vehicles off the road and more people out and about and walking.
I do understand that, Rachel, but when we're talking about air pollution, I feel that is a big factor.
Thank you, Rachel, for getting back to us on that one. And the next question we've got is from Councillor Pritchard, but we've only got time for one question after that, one supplementary after that, because we need to move on.
Good morning. Just a quick one. How effective have the new drones been in identifying domestic burning, and how many enforcement or advisory visits have followed?
I'll answer this one. Yeah, we're very excited about the drones. Unfortunately, due to Doncaster Council being classified as commercial by the Civil Aviation Authority, we have had to undergo further strict requirements before we can fly the large drone that we're actually going to use to go over villages and do a full survey. Unfortunately, this has caused delays whilst we ensure that all our drone pilots are fully qualified and can produce the mandatory risk assessment and method statements typically referred to as drone RAMs documentation, before each flight. This is a crucial document detailing potential hazards and control measures associated with the specific flight, including public safety. In addition, as a local authority, we also need to form an operating manual, which needs to be accepted by a qualified Civil Aviation Authority trainer. At present, this document is being prepared by a relative representative within our authority. Once these factors, along with the evidence of public liability insurance, have been approved, our pilots will receive their licences, registration and relevant certificates authorising their ability to fly. And then we'll be straight out there.
Thank you.
And the next question's regarding sexual and reproductive health. And we've got Councillor Squire.
Thank you. My question is, what's in place to educate young people's age, appropriate education? How young do relationships, sex and health education, RSHE, start in schools? And the second part is, it is good to see TikTok used to get the message out there. Do you use Facebook? Also, is it good to see the health bus and drop-in clinic sessions being used? There is an health bus going about, so...
So I feel way out of the age qualification to talk about TikTok, but I'll have a go. But first of all, let's talk about the relationships and sex education. So Department for Education set a statutory requirement for all pupils, so primary age pupils and secondary age pupils, to have education around relationships and around health. It's statutory only for secondary age pupils, but primaries can choose to deliver themselves a programme of sex education, and they're able to tailor that to what they think the needs are for their own primary school students, pupils and population. We do run in Doncaster a regular pupil lifestyle survey, so that helps us to bring in what we think is needed around all sorts of health and wellbeing topics in schools, and we support schools with that information. So it can be that primary age can be tailored to the particular need of the pupils. As part of our public health offer to schools, which is called Healthy Learning and Healthy Lives, we are currently developing a new curriculum or a new pack that schools can use, and we make that available free for schools to use as well. Just on age, there's really important elements of that in primary age, and it's about things like naming of body parts and what's important around a healthy relationship, and there are really crucial safeguarding elements as well to that. So if on the occasion a young person is in a really difficult situation, they're actually able to articulate what's happened to them by naming a body part. So some really important aspects to that as well. We do know from our local evidence pupil lifestyle survey and national evidence as well that secondary age pupils feel that they find out about these things too late, and they want to be educated at an earlier age rather than encountering these issues in their lives much later. So in summary, there's not a set age. We provide the resources free. There is a statutory requirement around health and relationships. The sexual health element comes in at secondary age, but we support the schools that do want to include that teaching. Sarah, is there anything else to add to that? No? No. Thank you. Oh, TikTok as well. I promised you the TikTok. Oh, Lord. Right. And this is, so I'll talk about the syphilis campaign particularly, and then Sarah will respond as well around what we've got available for sexual health and drop-in sessions too. So we've used TikTok. So syphilis we've mainly used for our campaign for this year, can affect all ages, and we've routed our comms through TikTok because that's where the age group that we're trying to target are most likely to frequent. I've not advised this. Our very smart communications colleagues have helped us out with that. Services do have a Facebook Facebook group as well. So Solutions for Health, our sexual health service in Doncaster, have a Facebook group with 206 followers, and I am one of those. I'm more in the Facebook demographic, I think, than the TikTok demographic. But we do, being able to use social media as well, we're able to keep a really strong look at who is engaging with that. So as well as seeing that information, who's clicking, who's accessing the information, and what we think the kind of conversion rate is. So what does that mean for a person? In terms of health buses and things that we use, so this was another enormous area of innovation through COVID. So the service that we've got in Doncaster uses home tests. So you fill in a form online, they deliver a test to your home. You can self-complete that and send it off, and it's got good specificity and sensitivity in that testing as well. We've also got drop-ins as well, like actual physical drop-ins of test results. And Sarah, are you okay as well to just describe that community offer? So it'd be good to hear how it's been in the year and then some of the recent changes to it as well. Is that okay?
Yeah, so the idea with, especially around the adult sexual health, is to make sure that anybody who would like a test can access the test in a particular way of their choosing, whether, as Rachel says, that's online. Our sexual health services now have tests available to be picked up from reception, so anybody can just call into the main sexual health clinic, pick up a test for chlamydia or gonorrhea, do their swab literally there and then, leave the test and go off. And so again, it's another way of making services open access, user-friendly, to help, you know, patients get their sort of results quickly, get their tests quickly. Just to sort of go on that point, things like online testing and those sort of picking up tests from the clinic, we would aim at asymptomatic patients. That's people that are not presenting with symptoms. They're people that just want to take care of their sexual health. If anybody has physical symptoms, we always suggest they get in touch directly with either the young people or adults sexual health clinic. And we're constantly exploring ways to increase that community testing offer. Like you say, the bus, that's a really good way of getting out there. They've had some really positive results with women accessing the bus for cervical screening as well. So we're hoping to piggyback on the back of that because, you know, people are wanting to access tests in different ways. We're looking at how we can expand community testing to support our adult sexual health services. We're looking at hopefully doing some more, having that more visual, like a more visual presence in the community, sort of destigmatizing people accessing a sexual health screen. So having like screening available at large community health events, for example, or like you say, when the bus is down at Clock Corner, you know, making it really clear that people can also come on there for a sexual health screen. That does involve a bit of planning and a bit of working with partners. We might have to get some external help because it is quite time consuming, and if we can work with some other external partners to help us with the community side, it means that our sexual health services and our outreach team can really focus on vulnerable communities, and we can get support to sort of offer that to wider communities as well.
Thank you. Have you got any further questions?
Hi. Just a thought on that. The community health bus service. I've actually used it once myself, but I didn't know it was actually going to be there until my wife saw it and said, oh, there you go, there's your opportunity. Is it not a good idea then perhaps to have, wherever that bus might stop, to have a bus stop sign with a timetable on it so people actually can be aware when they're walking past it, oh, I'll actually turn up there. And that's going to make it hopefully more accessible and more user-friendly, if you like.
Yeah, so Primary Care Doncaster have Vinny the van, and we've used them for all sorts of different things. I know talking to Michael Shaw, he is really keen to get that comms a bit more strengthened around it so people know about it. So yeah, I'll pass that on to him as well.
Thank you. We've got the next question from Councillor Carroll.
When I was in Sheffield Market not long back, I noticed that Sheffield Moor Market has a sexual health testing centre. It's open on a Wednesday and a Thursday, I believe, from 12 until sort of 3:15 in the afternoon. And I thought that was a brilliant idea. Do we have anything similar in Doncaster where people can just walk in or book an appointment to walk in on a particular daytime?
Not currently, but again, just following on from the conversation we were having earlier, we are looking at ways to increase access like that. And our sexual health services, having the drop-in slots available to just go and pick up a test. Again, we're trying to sort of use that as a way to maybe replicate something similar. Our service do offer if people ring up in the morning and there is an appointment available, they will get a clinic appointment available on that day. So yeah, the service are constantly evolving, constantly looking at ways to improve access to testing, and I think that's a really good example that we would try and replicate in Doncaster.
Yeah, I think it'd be a really, really good idea because, you know, sometimes I think people they think about it but then don't do it. But if you think about it and they're there, they're probably more likely to do it, I think. And the other thing is we have that Vincent van Gogh bus, which I think is an absolutely brilliant name. Can that be used for that, or is it used for that?
So we were just that was the same thing that we were just, so the van is the van, and we might end up with 100 vans in Doncaster, although I won't remind you of your conversation earlier about too many cars. But yeah, so Vinny is the van that we've got that we use for all sorts of purposes. I must say I was really sceptical when colleagues in the public health team said, we'd like to use the van to go and do some cervical screening. I thought, no one's going to get on a van and have cervical screening, but actually they have, and we've had people that have had their first screen ever on that van. So it's kind of showed me things that I wouldn't have believed before. So yeah, we've got the one van in Doncaster currently. I think it sounds like there's a case maybe for more of that, but we'll look to use that resource as well for some of that sexual health provision where possible.
Oh, that's great. Yeah, thank you for that. Yeah, I think the name is brilliant, and I didn't click on the Vinny bit to start with, but now I do.
Thank you for that. Next one, we've got substance misuse, and that's Councillor Pritchard.
Hello again. Do you find that Aspire outreach team is making a difference within Doncaster, and how?
Yeah, so I'll answer substance misuse questions today. We'd normally have Helen with us that could give you a lot of detail. So if I don't cover everything that you need for this question, then just let me know. So not even quite a year ago, we had a whole scrutiny session on substance misuse, and we took the scrutiny committee out to Sober Social, our lived experience in recovery organisation, and we heard from our provider Aspire about how they were establishing this what was called OAT team at the time, the Aspire outreach team. So they've been running now for probably around a year, and the real difference that it makes is that they're up early in the morning, way before I'm up in the morning, so 5 o'clock in the morning, walking the streets of Doncaster, looking to engage with people and bring them into treatment services. If they're not ready to engage with that yet, then bringing them into a space to start talking to them about engaging with services. So they're out there working with some of our more vulnerable populations, so think about our sex workers or people experiencing homelessness, so able to engage with them and bring them, introduce them into treatment, whether it's been their first time that have accessed services or their 6th or 7th time. In terms of being able to give you the details on kind of successful engagements with treatment and successful completion of treatment, I can ask Helen to put us a short summary together and I can distribute that round to the team as well. But it did feel like it was a real missing piece in the service for Doncaster. Like other areas, we've received additional national funding, which has been significant, but it recognises that drug and alcohol services have been underfunded for a number of years. So we've been able to restore components of a service that were missing, and this was one of those key parts of it. So yeah, all about getting out there, engaging people in with the service and doing that quite practically. So if you do want some more details in terms of successful completion rates and engagement, I can do that with Helen as well.
Thank you for that. Is there any supplementaries on that question? And the next one is Councillor Linley.
To what extent has naloxone carriage by South Yorkshire police officers been taken up, and has it resulted in any recorded life-saving interventions? Is it part of the regular safety kit? And it's not on here at the moment, but is there any training? I'm assuming there will be training for it. Yeah, over to you. Thank you.
Yeah, so me again, and filling in for Helen. So, and we have asked the police for their most up-to-date details, but I'll answer the bit that I can. So, when I started chairing the Combating Drugs Partnership about 2.5 years ago, and we, as part of a partnership, we said that we wanted to get that naloxone provision as wide as possible. It didn't start off as a simple process because the police themselves had to look at their terms and conditions, their employment terms and conditions, and feel comfortable with the carriage of naloxone. We have got a significant number of police personnel that now do carry the naloxone. I've asked them for the numbers, so again, I'll pass that on separately. Training, so it's Aspire that offer the Aspire, our drug and alcohol service. They offer the training in the use and safe carriage of naloxone. It's a pretty safe substance to carry, but they offer that training in administration of naloxone as well. However, it is entirely voluntary, so it's not required that all police persons must carry it, but our numbers are continued to increase. Your question about has it made a difference? So yeah, again, I'll ask for the precise numbers, but I know it's been used and it has saved lives of people in Doncaster. Thanks.
Thank you.
Thank you. Next we have Councillor Carroll.
Yes. So next steps in suicide prevention are looking really, really good. And I'd just like to say well done on that, by the way. But as regards sort of organisations that are available for people to go to, what organisations have we got and how are these actually publicised?
I'll answer that question. In terms of post-vention support or around mental health support for suicide prevention?
In terms of sort of in prevention, sort of post-preview.
Yeah, so we have what we term a Z card, a mental health Z card, so it's a little pocket size leaflet that opens out, and there's two sides to the card. It provides some local support, but also national support. We recently had them translated into multiple languages last year, and we distribute these out when we do events. So we will share them amongst our colleagues if they are holding the events in the community. In terms of post-vention support as part of the suicide prevention, people that are bereaved by suicide are at risk of suicide. So part of that prevention work is we have a support service called Amparo that supports practical and emotional support in the aftermath of a suicide. Part of our standard operating procedure in South Yorkshire, we have a suicide liaison officer that sits within South Yorkshire, will notify a system when there is a suspected suicide, and they proactively approach people that have been identified at that scene who might need that support. Alongside of that, Amparo have a really robust communications plan in place where they will come to community events to share the work that they do. They will also engage with our GPs, our community services, our police officers know about it, also our coroner's office. So it's a really good, robust communication plan in place. But also as well, they offer some discreet support as well for people that might be affected or impacted by suicides, but aren't directly within that family.
No, that's great. Thanks. No, and really well done. I think it's working really well.
Thank you.
Thank you for that. The next question's myself. What is the uptake in Doncaster covering 23-24 compared to 24-25 regarding the immunisation for adults and children? Is there a better uptake?
So this year I will send the data links to you, but this year there has been a very small increase in uptake in vaccinations of childhood immunisations in particular. Maternity vaccinations has been, we've got a really positive uptake of maternity vaccinations. There's a really strong vaccination programme antenatally within the hospital. Our school-aged IM services as well. There's certainly the last flu season, as we come to the end of this flu season, that data's looking really positive. Slight increase in primary schools and a more significant increase in secondary schools. The adult vaccinations, I'll have to get back to you. We've moved from working as an MMR and pertussis cell within Doncaster to a community of practice, and we're looking at different cohorts of vaccinations, and we're actually going to be looking at adult immunisations when we next meet. Okay.
And I know I remember as a child we used to have our vaccinations at school and then get a lump of sugar. Thank you. Does that not go in anymore? I know the sugar, no, forget the sugar.
No sugar, but school age immunisation services very much so. Yeah, we've got a very strong offer with flu vaccine, the HPV vaccine, MenA-CWY, and diphtheria, tetanus and polio as sort of that adolescent immunisation cover. In addition, our school age immunisation team now have authority to offer vaccinations to rising fives in areas of particular need.
Thanks, Julie. Just to add, in terms of the adult vaccines, I think the general trend is that they're stable, and Doncaster are not a particular outlier compared to the rest of South Yorkshire, Yorkshire and Humber or National A. We have seen significant improvement amongst vaccinations in pregnancy. So the pertussis, maternal pertussis vaccine particularly has seen a significant increase. The RSV vaccine for pregnant women has been well received, and again that's through a good engagement with our maternity provider. And we're also, in terms of the adult vaccines, looking to try and link in with the ICB development around the integrated neighbourhood services work that they're doing, that they're an agreed national pilot for that integrated neighbourhood service, service. So we'll look to link in with that, because again, one of the focus areas for that is vulnerable people that are likely to have recurrent admissions to hospital, etc. But generally the picture is stable.
Thank you.
I think there's more than one of you wants to speak there, isn't there?
Yes, I've managed to put some few slides here to kind of pick an example of one of those vaccination around MMR, partly because we have used that 2 or so years ago, to kind of do local exercise if we've got a measles outbreak. It is very infectious. So in fact, we did have some cases of measles, but this exercise has helped us to focus on how do we increase the vaccination uptake among our children. And over 2 years or so, we've kind of made some marginal increase. Obviously, there's still more work to do. And I picked that to kind of look at that kind of trend over the past 10 years or so, what the rate looked like. I know I've sent something to you, Caroline. Is it possible to put it on the screen? So it's a set of 3 slides. There is MMR within the first 2 years of a child life, and then MMR at uptake at 5-year-old. There are 2 doses. So I just want to kind of briefly talk you through that to show you what the figures look like. As Kathy mentioned, our rates are kind of comparable to the national rate. So this figure is available on what we call public health fingertips, as a public health outcome framework, the dashboard that kind of collate the statistics, public health statistics, and vaccination is one of them. And this is one of the vaccinations, a good indicators. And as you can see there, I put on the left-hand side the graph. England is the red one, Doncaster is blue, but you can see they are kind of neck to neck over the years. And this is for MMR, 1 dose for 2-year-old. And the latest information is that 90.2. And you can see for England it is about 89, just under 90, and we're kind of marginally above that. And then the second one is at MMR uptake, children who have at least one dose. Expectation is to have 2 doses. Again, you can see that the trend fairly quite neck to neck as comparable. Interesting to note that between 2015-16 to 2018-19, 19-20 as well, we were able to reach the recommended WHO target of 95% one dose, which is very good. But obviously, there and then there has been a lot of factors. We have slipped back. The intention is, even as a country, we will be able to get to 95%. England has missed that target now to be kind of 95% coverage of childhood vaccination. So still kind of striving to kind of work on that. One positive thing is with a bit of funding from NHS England in terms of around promoting children who have missed their vaccination to kind of do some bit of focus work on that with the help of health visitors. So we hope that that concerted effort will help us. And then the final bit is those who have 2 vaccinations at the age of 5. You can see the figures are a bit much lower. Again, it's not only Doncaster, England also kind of mirrors the same pattern. So that's what I just wanted to kind of share with you in terms of what does the trend look like over the years.
If we can get a copy of that, it'd be fantastic to have a look at it, because it's a bit
Yes.
blurry.
Caroline can share that.
Councillor Squire?
Do you actually have the figures for the uptake of vaccinations for Doncaster? I know we see the English average. Oh, was it? I do apologize. I was looking at the England, so yeah, right. Yeah, that's okay. Sorry about that.
Does that, because even though I've got my contact lenses in, I still couldn't see. Does that include like a statistical breakdown for schools in Doncaster and what the uptake is?
So it will depend on the vaccination, but you can, colleagues that will have access to that kind of patient level data would be able to look at it by GP practice registration, I think, and sometimes by school. Go on.
Yeah, so different vaccination programmes work in different ways in terms of what level of data we've got access to. So for MMR, which Victor's just presented, yes, we have a breakdown by GP practice, so we can see the variation that we have across the patch. There is, we do have access to an MMR school report that does go down to school level as well, and that's what we use with our school aged immunisation service to support that that catch-up activity. So again, we can see which schools have got the lowest uptake for both dose 1 and dose 2, which obviously then equates to that's where we've got the highest risk of an outbreak occurring. So again, in terms of targeted work, that would inform that. Unfortunately, it's not in the public domain, so we can't share that information. It's there for us operationally. We use it with our providers, but it's not something that we're able to share with the committee, unfortunately.
Right, okay. Because I was thinking it out like as from an educational point of view, you know, for which areas have got the least uptake, which areas have got the most uptake, and where we need to be looking at more, putting more effort in, effectively.
Yeah, and Julie might want to say more, but that's kind of our day-to-day work. So looking at the overall uptake, looking at the variations, and working with our providers to target those areas of whether it be deprivation, whether it be school. Unfortunately, for those programmes, going back to kind of the opening discussion, we don't have that information by ethnicity. Some of the programmes like flu and COVID, we do have with regards to deprivation and ethnicity, but we don't have that level of data for all of them. But that's Julie's kind of day-to-day work.
And that's picked up with the work that Victor spoke about with the health visitors, the targeted area, the pilot project that we've got underway in Doncaster at the moment for the next 12-18 months, and the areas that they've targeted, which are sort of areas based on low uptake, and that's reflected in areas of high indices of deprivation and high levels of different ethnicity groups.
No, that's great, thank you. I like stats. I'm a bit of a. I like to know.
The cover data is publicly accessible, and that breaks it down into areas and into GP areas as well.
Right, I'd just like to ask councillors if they've got any more questions. Now discussions have finished, I'd like to move on to the recommendations. These are set out at paragraph 11 of the report. Does the panel agree it has been reviewed, the information provided today that asks members to note the achievements, challenges and mitigations across the breadth of the health protection areas in 25-26 and the priorities and work planned for the forthcoming year, and note the overall assurance on health protection for the people of Doncaster. Can I ask if there are any additional recommendations? If so, what are they and what is supporting the reason for your recommendation? Is that agreed? Is it seconded?
Yep.
Well, thanks, officers, for the time, and move to the next item.
Right, everybody, we're just going to move on to the work plan and forward plan. I won't be too long. So basically, to note on the work plan, the next item that's coming up, but it's not for the whole panel, it's the Joint Health Overview and Scrutiny Committee that takes place at Sheffield, and that's attended by the Vice Chair, Councillor Carroll. So that's coming up in March. There'll be work planning meetings coming up in, I think, May or beginning of June, and we're starting work already. So that work's in progress and you'll be duly updated. And the forward plan, the items are mainly around the budget and the finance and performance reports. Although the quarterly finance performance report goes to OSMC, the chair is on the committee, and any questions, any particular areas concerning this panel can be relayed through the chair. So that's all I need to update.
Thank you, Carol. I would now like to close the meeting and thank everybody for attending today.